Thank you very much. Thanks, Jeff and Jorn, for organizing this wonderful meeting, and Alina, thanks for co-chairing this. And when a meeting starts with a great music like this in a city like Barcelona, I think you're going to beat everybody over the next decade to have this kind of wonderful meeting, and the faculty is just unbelievable. So my task over the next 20-25 minutes is to give you sort of a more of a general perspective about public challenges and burden of non-alcoholic fatty liver disease in 2022. And whenever I start my talk about burden of disease, I want to make sure that I take the comprehensive perspective that when you're talking about the burden of disease, you're talking about clinical burden, which is ultimately the surrogate is mortality, and it's hard to measure that. And in that context, we use easier things to measure. For example, we look at liver outcomes as surrogates, including stage of fibrosis or cirrhosis. Of course, prevalence and incidence is part of epidemiology burden. When you're looking at patient-reported outcome, these are basically those reports that come directly from patients about the patient's health and well-being and quality of life. Health-related quality of life is one of the surrogates. And of course, the economic burden, you can do cost of illness, one of the examples, or you can look at work productivity, whether it's absenteeism or presenteeism. These are some of the indirect economic impact of different chronic diseases. This is a paper we published in 2016 that suggested the global prevalence of Nafld is about 25%. The highest prevalence was actually in the MENA, Middle East region of the world. And at the time, the lowest prevalence was supposed to be in Africa. When you look at the prevalence of Nafld in children, at the time, that prevalence was about 7 and 8%. Again, very high prevalence in South America. And as you would see from Ken Kuzi's talk, the prevalence in type 2 diabetics is about 55%, 55.5%. Very high prevalence, and actually, again, in Middle East and North African region. When you look at the progressive form of fatty liver disease, which is NASH, that prevalence can only be estimated because you can't biopsy walking around in general population. So that steatohepatitis is a histologic diagnosis, as you know. That prevalence is about 1.5 to 6.5%. And type 2 diabetics is about 37%. Again, a lot more detail will come from Ken's data on diabetes. When you look at sort of country-specific prevalence in Europe, somewhere between 20 to 30%. In Asia, 24 to 51%. And as you can see, there's a wide range of prevalence rate, actually even from different regions that was reported. And that really took me back to say, okay, we need to really go back and look at the meta-analysis. And Jeff, for you, we took on this meta-analysis, which is really building on what we had in the past. And this time, we were much more careful in terms of selecting the studies so that you don't have overlap of patient population and very strict inclusion criteria. And in general, we include about almost 1,850 studies or 1,860 studies of over 11 million individuals who are included here. And you can see the distribution. And also, we wanted to look at the prevalence and the incidence and mortality according to the GBD regional distribution. So I'll share this with you. So in this analysis, now the prevalence of Nafld is about 29% globally. The highest prevalence now is in South America. Prevalence is 44%. In Middle East, still very high, about 40%. And in the United States or North America, that prevalence has now gone up to 32%, which is actually consistent with what we all see. Now, the key to this is you have to look at the studies on what modalities do you use to make the diagnosis of Nafld. So if you look at, say, ultrasound, and if you look at ultrasound and your cutoff is moderate to severe steatosis, which a lot of people from ENHANCE, including myself, use, that prevalence is about 15%, 15.4%. On the other hand, if you look at mild to moderate to severe fat on the ultrasound, then the prevalence is 32%. If you look at CAP, and even at some of the cutoff point that's well accepted, prevalence could be up to 40%. And as you can see, the risks are right here. So it depends on how the definition is done. And you don't want to really mix oranges and apples if you're not looking at the same criteria for prevalence of NAFLD. Incidence data for NAFLD is very, very hard to come by. This is the most updated data. So the incidence is about 44, 45 per 1,000 person years, almost twice as much in the obese population, about half as much in the non-obese population, as you can see, about 22 per 1,000. Now, when you look at different stages, this is not from our study. This is from a different study. This is from U.S. epidemiology study, US data. Try to give you as much global data as I can find. But you can see that about 16.5 million people presumably have NASH in this, according to this study, but only about 1 in 20 has actually been diagnosed. About 1 million people, and the vast majority of them, over maybe almost 3/4 of these individuals, will have early stage of non-alcoholic steatohepatitis with F0 to F2, and about 240,000 or so will have the higher stages. This is, again, a relatively older study and needs to be updated. What are the trends? This is the study we actually looked at the enhanced data set from the United States and looked at 4 common liver diseases. And as you can see, hepatitis C is coming down nicely here. Hepatitis C is going down in terms of prevalence. Hepatitis B and alcoholic liver disease in the United States over 3 decades is stable. NAFLD is the only one that's going up. And this is the multivariate analysis showing that there are a number of things that drive this high prevalence, but primarily it's driven by obesity and type 2 diabetes. And that's one of the main discussions that we will have. That was the US data. This is the global rates from the recent meta-analysis that we have performed. And you can see that that's replicated in the global rates, depending on the sort of periods of time where actually the data was collected globally. So you can see we went from 24% up to 36% over the past 30, 40 years. Incidence, the prevalence of NASH, again, has been estimated to go up in different regions of the world. Again, this is from the modeling study that Razavi and his team has put together. I suspect that if you actually use the same data from our meta-analysis, you'll see the same thing. We haven't done this part yet. So what are the drivers? The drivers are known to you, some of them, and this is basically the map of obesity, and the red areas that you see correlate very well to the red area of the prevalence of NAFLD in different regions of the world. And this is type 2 diabetes. This is a review paper that Ken Kuzi and his colleague put together, and I'm sure he's going to show more data on this in terms of diabetes, quite prevalent in all regions of the world. And this is actually a nice paper that accompanied our first meta-analysis that look at caloric intake and how you actually can see that caloric intake also is associated with high prevalence. In North America, as you can see, prevalence was 24%, then very high prevalence of caloric intake. And when you look at activity or lack of activity, the left is in men and the right is in women. This is in 2016. Again, red and different shades of red suggest lower activity, higher percentage of individuals that actually have low activity. And you just look at the MENA regions for women. Look at that. Most of that is actually in red, suggesting that the lower activity would actually be associated with higher prevalence. And I'll show you burden in a minute that correlates with this. And of course, there are genetic drivers of this. This remains somewhat controversial, but I can tell you that, again, the PNLP3 as one of the surrogate of genetic predisposition is also high in certain populations, especially in Hispanic Americans as well as in South America, quite high. Very quickly, the natural history of non-alcoholic fatty liver disease. It's important to remember that most patients with fatty liver disease will have non-NASH type of fatty liver disease, and they don't really progress in general. I think this is controversial, but I believe that most of them don't progress in terms of liver disease. It's also important that the number one cause of death in patients with NAFLD is cardiac, and I actually listed here all the other sort of extrahepatic manifestations, sarcopenia, the extrahepatic cancers that Alina has been working on for quite a while. So some of these are very important. But when you look at the progression of fatty liver, especially NASH, about 15% of patients can progress. And probably there are a number of sort of things that could promote this. Again, this is a cartoon And you can see that things from, cytokines and adipokines that are secreted from white adipose tissue, as well as maybe PNLP3 could have actually the M genotype, the homozygous M genotype of PNLP3 may actually be a predictor of progression. The key to this disease is that progression is not homogeneous and it's not linear. So you have periods of progression followed by periods of regression or stability. And of course, this is the problem in clinical trials where you have very high placebo rates, probably because of this. And that needs to be addressed. So this makes this disease progression in natural history quite complicated. Consequences, this is also from our meta-analysis. So when you look at mortality is about 17 per 1,000 person years mortality. This is twice as much as in general population. When you look at the cause-specific mortality, the top 3 causes, heart, extrahepatic cancers, and liver-related could explain about 65% of mortality here, and they're all listed here. Now, modeling, this is again from Rezavi's data. Complications over the next 15 years or 20 years has been expected to increase. This is the US data, and you can see it in Europe and Asia and any other part of the world. And when you just look at the number of patients that will have significant liver disease from Nafld, just in EU and North America, it's estimated to be about 5 million. This is the data from the NASH CRN that Arun Sanyal published in New England Journal of Medicine, I think, just recently. And as you can see that depending on the stage, you can actually get significant complications and increase in complications over the 7.5 years or so, where it's actually related to HCC or variceal bleeding or ascites, or especially an increase in the MELD score. The MELD score has increased substantially in these patients. So this is some. Now, of course, these are patients with more advanced liver disease. This is data we published a few years ago from the National Death database of the United States. And as you can see, over the past decade or two, there is actually an increase in the mortality related to Nafld, both in men and women, although the rates, annual percent change, was higher in women than in men. And when you look at the causes of mortality, the highest rate of increase happened which was related to HCC, related to NASH. So that's an important issue. This is real-world data. About a third of these patients is from an Optum data set that was presented last year at the liver meeting. Again, the key to all of this is that when you look at real-world data, you see that a lot of the complication rates on the top right table are listed there. When you look at the incidence of mortality related to Nafld, it's similar, maybe a little bit higher, just because you're probably going to get some biased data here than the rate I showed you from meta-analysis. Liver transplantation is another important outcome. This is all patients, and as you can see with the red line, hepatitis C is going down. This is from our data that we published, and both Nafld and alcoholic liver disease is increasing. And when you look at liver cancer-related liver transplantation listing, you can see that the yellow bars are increasing in size, meaning that the proportion of patients related to Nafld on the list are increasing, and that's also shown on the green line here. Global data, we published this a couple of years ago, looking at GBD data. Just look at the mortality and look at boxes. These are different regions of the world, and as you can see, in every region of the world that we're looking at, both mortality from liver cancer and cirrhosis are red, suggesting that the annual percentage increase related to Nafld is increasing. If you look at the hepatitis B, for example, in Asia specifically, that's actually going down, and that's in green. That's probably related to vaccination in other areas. And of course, in addition to incidence and mortality, DALYs, of course, will put in the morbidity sort of context into this. And again, when you look at the DALYs that are related to Nafld, the highest increase was in North America and the United States. So again, even if you look at DALYs, which is an important surrogate for burden, it's increasing globally from Nafld. And finally, as I alluded to, Nafld is very, very prevalent in Middle East, and here we're looking at MENA region in Asia, again from Global GBD 2009-2019. Half of the liver complication related to fatty liver disease occurred in this region of the world, half of it, and was driven by not only sort of the metabolic risks, but primarily by lack of activity and maybe in some areas with diet. So that's actually a hotbed of Nafld, as you would expect over the next decade or two. We talked about clinical predictors. This is basically looking at type 2 diabetes as an important predictor of mortality. Metabolic syndrome, of course, is important. This is a study we published a few years ago, looking from enhanced. The more component of metabolic syndrome you have, the higher the mortality. So that's, of course, why we have such a great interaction with our colleagues, our champion in endocrinology, Dr. Kuzi here, my friend, is that's really where a lot of these patients actually reside. We're going to only see in hepatology the tip of the iceberg. When you look at sort of other predictors, histology being one of them, stage of fibrosis is independent predictor of mortality, stage 2 or higher. And in that context, when you look at the data we published using the Stellar 3 and 4 data, when you look at liver events, and if you had actually regression of fibrosis, liver events actually was reduced significantly. So it's not only a predictor of bad outcome, but regression can also at least suggest that those outcomes could potentially improve. And this is, of course, histology. Now we have to also look at non-invasive tests. We published in Gastroenterology last year too, looking at FIB4 and looking also at ELF. And you can see the same thing, that actually a certain threshold of FIB4 and ELF can predict bad outcome in terms of liver events in these patients. Finally, I mentioned PNLP3 as an important predictor of high prevalence. This study actually shows the potential for bad outcome related to the sort of mutant genotype that's actually associated with more adverse outcome. We have known this, and there's actually mortality data. I can't finish a talk without giving you data on PROs. This is quality of life data that we have published, two of them. The more advanced liver disease you have, the more impairment of quality of life. Usually when you use a questionnaire like CLDQ NASH, which is what I use. And when you actually look at improvement, this is actually by non-invasive tests, ELF and FIB4, you will have improvement of PROs. This has been now shown on multiple occasions. Economic burden, we've done about 5 or 6 economic analysis looking at Markov model. This was our earlier sort of study. This was presented last year at the liver meeting. And as you can see, the vast majority of the cost associated, this is a 20-year cost, associated with Nafld was in more advanced patients that you would expect, or obese patients. But there is also a substantial $48 million that's actually associated with even non-lean, non-obese Nafld. And the cost increases with age, as you would expect, just because we probably would have more advanced liver disease as you age. 2 minutes on epidemiology of lean Nafld. The prevalence could be, in the United States, about 5%. And the rest of the world, say in Korea and South Korea, could be as high as 25%. This is from a global Nafld registry that a lot of our colleagues have been a part of, 20 different countries, the prevalence of lean Nafld. And this is, of course, you have to adjust for the age and sort of definition of BMI, was about 7%. Outcomes, there's controversy here. Our data from ENHANCE suggested that lean Nafld is more aggressive. And when you look at the study from Laurent Safreti from France, about 6% or so had lean Nafld, and they had actually more adverse outcome here as well. When you look at the study from Sweden, there were more liver complications when they followed these patients for about 20 years. 600 and some patients for 20 years, but mortality was not increased. And I would submit to you that if you follow these patients, maybe they will have higher mortality in time. Hong Kong data, of course, is the opposite. They did not actually show a difference in mortality. But just look at the number of months of follow-up, only 49 months. And of course, this disease is not going to change in 49 months. So the final study that we published recently is to really not look at lean or obese based on BMI. If you look at the top box, if you actually look at obese, lean individuals based on just BMI, and you're lean both by body mass index and by waist circumference, then the mortality is lower after 22 years of follow-up than if you're obese by waist circumference, but you're lean by BMI. So in my view, this is actually all driven by visceral obesity rather than body mass index. So in summary, in 2022, chairs, I think NASH and NAFLD remain a growing global challenge. The prevalence of NAFLD is driven by metabolic abnormalities, as well as diet, activity, and possibly some genetic factors. The clinical burden related to liver complication and associated liver transplantation, mortality, DOLIs are substantial, and they're growing everywhere, specifically in Latin America and Middle East and North African region of the world. And there are some potential genetic as well as clinical and histologic, and in fact even NIT sort of predictors of prediction that we can use to prognosticate these patients. So in addition to the clinical burden, I've always encourage our colleagues to pay attention to what really matters to patients, which is patient-reported outcomes, and this is also a substantial burden, both from a PRO and economic burden. So thanks again for inviting me, and thanks for listening.